Hello, this is Dr. Kritika, Reader, Department of Oral Medicine and Radiology, SRM Dental College, Ramapuram campus. This is a short gist on the classification of salivary gland disorders along with the functional disturbances. Saliva is a clear, slightly acidic mucoserous secretion. It enables the cheek, tongue, and the lips to slide easily over the teeth, facilitating speech, smiling, chewing, and swallowing activities. Enzymes present in the saliva protect the oral mucosa and the teeth, and also it irrigates the mouth of food debris and also the oral microbial organisms. These are the roles of saliva, which includes it mineralizes the dentition, it facilitates digestion, dilutes sugars, enhances taste, maintains proper pH balance, prevents infections, and promotes healing. So the production of saliva, the saliva is produced by the major and the minor salivary glands. The major salivary glands include the parotid, the submandibular, and the sublingual glands. And the minor salivary glands include the labial, the buccal, the palatine, the tonsillar, retromolar, and the anterior and the posterior lingual glands. This is a short mechanism of how the saliva is produced. So, the saliva has got the neuromuscular innervations, which is caused by one of these two divisions, which is the sympathetic and the parasympathetic. The sympathetic division is responsible for the production of dry, thick, and ropey saliva, whereas the parasympathetic innervation causes the production of thin, watery, and profuse salivation. These two divisions work in oppositions and have the ability to physiologically alter the quality as well as the quantity of saliva. The salivary flow. An average person produces approximately 0.5 to 1.5 liters of saliva per day. The salivary flow peaks in the afternoon. It decreases at night when the major salivary glands are less active. Classification of salivary gland disorders. So classification is based on the following subdivisions. First, we begin with the developmental abnormalities of the salivary gland, which includes aplasia or hypoplasia, agenesis, aberrant salivary gland. Example is Staphnase bone cyst, accessory salivary ducts, and diverticuli. Obstructive diseases include silolithiasis and mucocele. Inflammatory lesions of the salivary glands are commonly referred to as sialadenitis, and it could be viral, bacterial, or fungal in origin. Viral causes can be mumps, cytomegalovirus infections, HIV infections, and hepatitis infections. Bacterial causes could be bacterial sialadenitis, can either be acute or chronic. Next is the obstructive sialadenitis, which is otherwise known as sialolithiasis. Next is allergic sialadenitis. Then comes systemic granulomatous diseases like sarcoidosis, actinomycosis, and tuberculosis. Necrotizing sialometaplasia is a reactive lesion. Sialadenosis includes the endocrine and metabolic causes. Examples are alcoholic cirrhosis, diabetes mellitus when it is uncontrolled, eating disorders like anorexia and bulimia, and malnutrition. Immunologic disorders like the Sjogren's syndrome and Meckel's disease are included under this category. Functional disturbances are the most important, and it includes xerostomia and sialorrhea. Drugs can also reduce or increase the salivary secretion, which includes isoprenaline, iodides, chlorhexidine, and so on. Salivary gland neoplasms are the last category in the classification of the salivary gland disorders, which can be broadly grouped into as benign and malignant conditions. The benign salivary gland neoplasms include the pleomorphic adenoma, which is the most common, followed by the monomorphic adenoma, the Wharton's tumor, and oncocytoma. The malignant tumors of the salivary gland disorders are mucoepidermoid carcinoma, adenoid cystic carcinoma, acinar cell carcinoma, squamous cell carcinoma, lymphoma, and adenocarcinoma. Next, we go on to increase in the salivary secretion, which is otherwise known as thialism, sialuria, or hypersalivation, and it is a functional disturbance or variation in the production of saliva. So, thialism is defined as abnormal spillage of saliva from the mouth onto the lips, chin, and the clothing. So, there can be many causes for thialism. Some of the most common causes are pathological conditions, gastrointestinal reflux disease, pregnancies, drug-induced, can be idiopathic or unknown cause, neuromuscular disorders like mental retardation, Parkinsonism, cerebral palsy, and epilepsy. The clinical features include drooling in, in children, could be because of inadequate swallowing rather than excessive production. Discomfort is felt as a result of excessive drooling, and there could be discomfort in speech and performing various other functional activities. The affected person may require numerous clothings to change per day, and there can be scarring, lip chapping, and other infections that could occur secondary due to such drooling conditions. Treatments generally includes a multidisciplinary approach. Glycopyrrolate 1 to 2 milligrams twice or thrice daily, or 1 milligram 60 minutes before a dental procedure is mandatory when a dental treatment is to be provided for people with thialism. Atropine sulfate, 1 drop under the tongue, can also be given before dental procedures so as to temporarily reduce the production in salivary flow and also to ease the performance of a dental procedure. Next is xerostomia. Xero means dry, stomia means mouth. So xerostomia is a subjective complaint of a dry mouth by a person. The etiologic factors that could cause xerostomia include autoimmune conditions like Sjogren's syndrome, graft versus host disease, rheumatoid arthritis, and sarcoidosis. Infections like AIDS and hepatitis can also manifest with dry mouth. Metabolic conditions like diabetes mellitus can manifest with dryness of mouth. Salivary gland aplasia and agenesis along with silolithiasis can be a cause. It can be induced by drugs as a result of radiotherapy, any psychological disorders, and other miscellaneous causes. What are all the symptoms of xerostomia? Soreness or burning mouth, lips, and tongue is the most common presenting symptom. There can be sleep interruptions due to thirst or oral discomfort, difficulty in chewing, speaking, swallowing, and wearing dentures, difficulty in clearing oral debris. Patients complain of dryness, altered taste, altered sense of smell, and an aversion to eating dry foods. Next comes the signs of xerostomia, which includes dry sticky oral tissues, ropey thick or frothy saliva, ulceration of oral mucosa, cracking or fissuring of the corners of the mouth or the tongue, halitosis, recurrent candidal infections, increased dental decay, increased calculus deposition, red gums that can bleed easily. These are some of the clinical presentations that could be seen as a manifestation of dry mouth, which includes depapillation of tongue, angular cheilitis, xerostomia-induced caries, and candidiasis, which can occur secondary as a result of decreased salivary flow. Secondary fungal infections occur, which can lead to candidiasis. So these are some of the signs, which includes the tongue blade and the lipstick sign, wherein due to a decrease in salivary flow, the mouth mirror tends to stick to the oral mucosa, or even a wooden stick tends to stick to the oral mucosa, which is a characteristic feature. And the shed epithelial cells can be notably seen when there is reduction in the salivary flow over the anterior teeth. So that is also a sign of reduction in salivary flow, which is called the lipstick sign. So what are all the investigations that can be done is milking the gland and to check the salivary flow rate, and also to measure the salivary flow rate by salilometry. So the treatment of salivary gland disorders will include frequent water sips, saliva substitutes, and using ice chips and drugs. The drugs that could be used are pilocarpine with a dose of 5 to 7.5 milligrams 3 times a day for 3 months, and cholinergic parasympathomimetic agents with M3 muscarinic action, which will stimulate the residual function of the salivary gland. The main side effects would be sweating and increase in urination. The next drug that can be used is cevimeline, a dose of 30 milligrams 3 times a day for 3 months, which is a cholinergic agonist and has also been successfully used in the treatment of xerostomia, but reports differ regarding their efficacy. Antifungal agents are given in order to prevent the secondary infections such as candidiasis that can occur due to the reduction in salivary flow. Antifungal therapy, both topical and systemic, are prescribed for a period of 7 to 14 days. The systemic antifungal agents for the treatment of candidiasis includes 150 milligrams of proconazole, and patients are advised to take care of the removable appliances, including night guards, especially when there is a decrease in salivary flow, so as to avoid reinfection. Thank you.